Very good, thank you. So this is a slightly tricky talk. I'm going to talk to you a little bit about the lung-kidney interactions. There were a number of different ways I could have taken this, but I'm going to adopt a rather sort of practical approach about how we consider fluid management in our patients with ARDS and the interaction of kidney failure with that. And obviously, a lot of these reflections are based on our experiences during COVID-19, a sort of unique clinical model of pure ARDS with a very high patient burden, but a lot of the evidence actually arises from before COVID, but coloured our clinical experience during COVID. I have a few academic disclosures, none of which are particularly relevant to this talk. And so to move on to the situation that we have here, and as we say, I'm going to adopt COVID-19 as a bit of a model for our discussion of ARDS, but these comments are broadly applicable. And in COVID-19, we had hypoxic respiratory failure, we had high fever, systemic inflammation, we often had the development of multi-organ failure and a significant instance of AKI. But importantly in this condition, usually a disease that was led by respiratory failure with multi-organ failure and acute kidney injury sort of following largely after the institution of mechanical ventilation. However, the influence of management before the institution of mechanical ventilation is interesting, and what the impact of that is on the development of subsequent AKI. And we have data here about a number of hospitalized patients with COVID-19, and this is some early data from New York. But what you can see here is there were substantial instances of acute kidney injury, as indicated here by the various bars with increasing severity. And what you can see is that there was the more severe AKI and the need for renal replacement therapy was broadly in those admitted to the intensive care unit requiring multi-organ support. And we also looked at this in our unit in the Royal London Hospital and other hospitals within Barts Health. This is data from the first wave. We actually have probably about 3 times as many patients in the second wave, which we're undergoing some further analysis on. But what you can see is that, and this is all hospitalized patients, acute kidney injury was relatively common, and the institution of renal replacement therapy in the ICU was again relatively common, but in particular persistent severe acute kidney injury was something that was strongly associated with mortality in our population. And so clearly there is an important interaction between a primary pulmonary disease with the development of acute lung injury and ARDS, and then the subsequent development of kidney failure and the risk of death. And so this sort of brings us over to fluid therapy, and we can think about fluid therapy in the context of many different disorders, sepsis, ARDS, and AKI. And we really have this existential conflict in the ICU. We have the desire to resuscitate, to provide a cardiac output and oxygen delivery, perfusion pressure, and we have the desire to prevent fluid overload with all the adverse effects of fluid overload on organ systems, in particular the lung. However, it's very important to note, and I've made this point throughout my career, that fluid overload does not just affect the lungs. While pulmonary edema may be very obvious, the instance of interstitial edema can worsen hepatic function, gut function, brain function, cardiac function, wound healing, and of course it can also adversely affect kidney function. It's well known that fluid overload is associated with adverse outcomes in patients with acute kidney injury. As I've said before, there is a direction of causality element here, but clearly if you have an AKI and you are fluid overloaded, you are going to have a worse outcome, and there's no specific cutoff. The more fluid overloaded you are, the worse your outcome at the institution. This is a study looking at the institution of renal replacement therapy, but other data, a less severe AKI is very similar. And you should be well aware that fluid overload and interstitial edema are actually intrinsic parts of the development of AKI. Patients with AKI have edematous kidneys. They are larger in volume. the relationship between volume and pressure inside the encapsulated kidney is not linear. As you increase the volume of the encapsulated kidney, the pressure inside the kidney rises dramatically. That pressure opposes glomerular ultrafiltration. It also opposes venous outflow, and the combination of these things can cause the sort of cessation of GFR. And what we find is that as the kidneys recover, there is usually a kind of a positive feedback loop. We get the resolution of fluid overload, and brisk diuresis ensues. It's important also to note that venous congestion, as indicated by central venous pressure, is bad for the kidneys. While some years back we would have said that in shock we should target a venous pressure of perhaps 8 to 12 in order to be ensured that we're not in hypovolemia and causing underperfusion of vital organs. That is not a physiological central venous pressure. None of us in this room hopefully have a CVP of between 8 and 12. If we do, then we certainly have something wrong with our hearts. There is some good evidence that there's a linear relationship between increasing CVP and the risk of new or worsening kidney function in critically ill patients. That's not to say that we should be taking steps to immediately reduce the CVP in these patients. That could potentially compromise forward flow, but it's to indicate that venous congestion has a very important etiological role in the persistence of acute kidney injury, and that it shouldn't necessarily be a resuscitation target. And indeed, CVP targets have been broadly removed from sepsis guidelines. So when we consider our patient with acute kidney injury and potentially lung injury, we've got to think about how we remove fluid. We've got to think about what goals we set. As our goal organ function, in that we're seeking to improve pulmonary function, and that may very well be the case if our patient's on 100% oxygen, very high PEEP, and we are considering whether to escalate them to a therapy such as ECMO. However, we may also be wanting to be aware of kidney function in our management, and clearly we don't want to precipitate worsening kidney function by inappropriate fluid management. And so, as I've said, the goals when we institute mechanical fluid removal are really to sort of restore the homeostasis that normal kidney function should do. And so we want to sort of allow the necessary interventions to our patients. We want to potentially slowly resolve fluid overload and its adverse effect on organ functions, but at the same time we want to avoid overt intravascular hypovolemia, secondary organ injuries in our patients. And that can be an extremely delicate balance, and the priorities we give to different elements here are going to be determined by the clinical status of the patient. If our patient is relatively hemodynamically stable but extremely compromised in pulmonary function, we may want to favor fluid overload treatment, but we may find out having to alter our targets as the hemodynamic situation changes. And just to re-emphasize, and you're going to have another talk later which will go into this in more detail, when we are removing fluid from the body, either via the kidney or via an extracorporeal mechanism, we are removing it from the circulation. However, the interstitial edema is in the interstitial space, which almost becomes like a sponge and is retaining fluid. And in fact, we can have relative vascular underfilling in the context of severe fluid overload and, say, pulmonary edema. And this is exacerbated by alterations in the microvasculature, loss of endothelial glycocalyx. So the tolerance of fluid removal in our sick patients with systemic inflammation, multi-organ dysfunction is far worse than it would be in, say, a relatively stable hemodialysis patient. And therefore, the rate of ultrafiltration that can be tolerated is not just determined by the amount of fluid overload, but by the hemodynamic status of the patient, their hemodynamic reserve, and the degree of lymphatic return and the other processes that lead to vascular refilling. And this is just to note here that adopting, therefore, a very fluid restrictive approach is not universally beneficial to kidney function, as we kind of perhaps have been advocating a few years ago. This is nothing to do with lung injury. This is the RELIEF study, which is looking at major surgery, and there had been a perception that fluid overload after major surgery was worsening a number of outcomes, such as pulmonary complications, wound healing, etc. And one should adopt a more restrictive approach in these patients who inevitably have fluid losses and systemic venodilation during surgery. And what the RELIEF study, which adopted a very relatively restrictive fluid approach, found was no difference in the overall disease-free survival outcome. But in fact, they found that there was a cutting point. If you do dramatically restrict fluids in a situation where there is potential demand, then you can worsen the incidence of acute kidney injury and need for renal replacement therapy. It should be noted that these surgical patients have relatively more intact circulation, less capillary leakage than somebody with systemic sepsis, may even be able to slightly better tolerate a fluid restrictive approach. On the other hand, may also be slightly at less risk of fluid overload and more able to deal with fluids that are administered. So a slightly different population, but still some telling conclusions. So let's cut to our sort of ARDS patient. Clinical status: they have bilateral pulmonary infiltrates, impaired oxygenation as indicated by their PF ratio, their PEEP, their need for extremely high levels of oxygen while on mechanical ventilation, fitting all the criteria for moderate or severe ARDS. And they may also have AKI. Fluid overload is not the cause of their ARDS. This is not pulmonary edema. And of course, you are well aware that pulmonary edema in its own right is an exclusion for the diagnosis of ARDS. But it is well accepted that fluid overload in the context of damaged and leaky pulmonary endothelium will contribute to the severity, the clinical severity of ARDS, and therefore we want to address that. But the problem is as well, this patient is potentially hemodynamically unstable, and that is going to be exacerbated by the provision of mechanical ventilation with high intrathoracic pressures, which will compromise right ventricular filling and therefore make your patient much more vulnerable to the effects of transient intravascular underfilling because of the compromise of RV filling on the high intrathoracic pressures. This has been a very interesting area and focus of research for some time. It's perhaps sad that the best evidence really comes from the FACT study, which is now a very old study, published in 2006. And it sort of ages me that I remember this coming out. And this was looking at, in the US, applying 2 different fluid management strategies to patients with acute lung injury. On mechanical ventilation, and the aim was to look at survival and liberation from mechanical ventilation in this population, and they studied a liberal strategy, which is essentially standard of care, versus a very protocolized conservative strategy to try and limit fluid overload. And overall, the study was negative in terms of survival, but the conservative strategy did result in more liberation from mechanical ventilation. And the FACT algorithm, this was a study that also was trying to investigate the utility of pulmonary artery catheter in the management, and so there was a second factorial randomization to pulmonary artery catheter, which is why there's this rather complex schematic here. But essentially, what they tried to do was, first of all, look for relative hemodynamic stability, and then if there was relative hemodynamic stability and there was evidence of fluid excess related to elevated CVP, pulmonary artery occlusion pressure, and there was inadequate urine output, then they would give diuretics, and if they felt that the cardiac index was inadequate, they would provide other treatments to try and elevate the cardiac index. If there was the fluid would only be given if there was evidence of inadequate circulation and the absence of indications of fluid overload. Now, what was the actual result of applying that protocol? Well, it's very interesting to look at. And so what the liberal fluid management, what the routine practice was in ICU, at least in those days, was a continuous accumulation of fluid leading to a very significantly elevated fluid balance by day 7. And I think that this is something that still occurs. It is very common to come and see intensive care patients having a continuous fluid creep, either from the administration of just routine medications, perhaps the use of maintenance fluids where it is inappropriate, and perhaps the accumulative effect of boluses of fluid given for small hemodynamic changes. The conservative approach was, however, able to achieve an effectively neutral fluid balance. It is important to note that there was a pre-randomization fluid balance of almost plus 3 litres. In this group, in these patients, no difference between the two groups, but effectively you're not resolving that initial resuscitation, you're just maintaining the status quo with the liberal approach. Now, there have been a number of analyses of the FACT study since then looking at kidney injury. I'm a little critical of the methodology used, which I think paid too much attention to fluid balance, its influence on AKI diagnosis. But effectively, what this particular study does is it demonstrates an interaction between AKI and fluid overload. And so to cut a long story short, what I think this study shows is that if you have AKI and you had a positive fluid balance, you had a particularly adverse outcome. If you had fluid overload as well, and perhaps borderline AKI, you also had an adverse outcome. However, if you had AKI in the context of a negative fluid balance, perhaps the AKI had arisen through the adoption of a more conservative approach, then that was actually less associated with risk of death. And so really emphasizing whether or not you think of it as a diagnosis change or just an interaction, that there is, that AKI and fluid overload is really the evil player here. So there was some thoughts about how best to operationalize this kind of approaches in the FACT study to enable good management of ARDS patients, perhaps without some of the complexities of the original study, and also perhaps to provide a little bit more of an in-between approach, given the fact that the very conservative approach might be difficult to administer in some patients. And so they developed this sort of FACT light protocol, and they compared that to the historical data from the FACT study. And the FACT light protocol produced a slightly more positive fluid balance, although perhaps if you reflect insensible losses, that would be around about even compared to the FACT conservative. In fact, the ventilator-free days performance was similar, the acute kidney injury incidence was similar, and the incidence of new shock was lower. And so this kind of said, well, the FACT approach is useful, but actually we can operationalize it with a slightly simpler protocol, and the slightly simpler protocol really was to give furosemide in patients with lung injury who were hemodynamically reasonably stable and were felt to particularly to be more oliguric, and to have some general principles such as the discontinuance of maintenance fluids in these patients with lung injury, and a kind of a rational approach towards shock using a balance of fluid resuscitation where appropriate and vasopressors. And so really reflecting the fact that these patients with ARDS, their management is really in a kind of an optimization and stabilization approach to intravenous fluid therapy in the ICU. We're trying to maintain patients on a plateau. As they later improve from the overall organ failure, we're going to be able to de-escalate them. Before they've got to the ICU, they've had some rescue resuscitation. We're not going to try and get rid of that. We're trying to prevent further deterioration. And so this is the kind of principles we applied in COVID-19. What we found at the beginning in COVID-19, particularly actually outside of the ICU, was that people were being faced with patients with lung injury, and they were keen to manage them in the best way that they thought they could prevent deterioration. And they perhaps read a number of the things that we'd written over the years about the problems with fluid overload, and they were adopting a very zealous approach perhaps to drying out these patients with bilateral pulmonary infiltrates. However, it should be noted these patients probably had not had initial fluid resuscitation because they generally presented relatively hemodynamically stably with breathlessness and pulmonary infiltrates, and not with multi-organ failure or indeed with hemodynamic instability and sepsis per se. And often patients had been isolated at home for some time, maybe breathless, not able to eat and drink, and were potentially relatively dehydrated. And so we were a bit concerned that we were adopting a kind of overly conservative approach, but that we shouldn't neglect attention to the fluid balance management in these patients. And so what we said was we should adopt the principles of FACT Light to aim for a daily fluid balance of even to plus 500 after any initial fluid resuscitation and a stable body weight in these patients. We shouldn't be aiming to aggressively diurese patients who weren't necessarily fluid overload. We'd be aiming to prevent fluid overload worsening their lung injury. And then when patients were getting towards the ICU, we needed a and many of these patients were then on non-invasive ventilation. We needed to very zealously monitor their fluid balance, monitor their renal function, pragmatically use diuretics, so we felt the patient needed them to manipulate their fluid balance, but to also monitor for the development of hypovolemia, and this was our sort of adaptation of the FACT Light protocol in order to achieve that. This was an adaptation where we had slightly greater degree of hemodynamic monitoring. Patients who are hemodynamically unstable needed much more individualization by an intensivist. And so just to reflect on outcomes in COVID-19, particularly with regard to renal outcomes, these is the data. It's a little old now, but this indicates that in the UK we had two major waves of COVID-19, the second wave being much worse than the first, and then some stuttering third wave throughout late 2021, early 2022. And in the first wave, in patients in the ICU, there was over a quarter got renal replacement therapy, and the mortality with renal replacement therapy is significantly high. It's important to note that 95% of patients who got renal replacement therapy were mechanically ventilated. Really, renal failure to the extent that patients needed RRT was a phenomenon of patients in multi-organ failure in COVID. It wasn't patients who were presenting with severe AKI. And what we found over time is that the number of patients requiring RRT decreased. However, the mortality of those patients did actually increase a little bit. That's probably indicating perhaps an overzealous use of RRT early on. Perhaps some patients who are less sick who didn't need it were perhaps being used. Maybe also we're slightly more enriched in end-stage renal failure patients as we get through, who may have a worse prognosis if they get admitted to the ICU, although that's slightly debatable. But a number of reasons for this. But overall, actually, the main picture is a significant reduction, a sort of halving of the number of patients needing RRT. And this may well be reflected to better supportive care and the institution of care directed at the lung injury, specific treatments directed at the lung injury, such as steroids and IL-6 antagonists subsequently. And if you decrease the lung injury, you decrease the multi-organ failure, decrease the systemic inflammation, you're likely to decrease the severity of the acute kidney injury. And it is notable that in studies that were from the recovery group, that confirm the benefit of steroids and tocilizumab in the outcomes of COVID-19 lung injury. One of the significant effects of these interventions was a decrease in the number of patients requiring some form of renal replacement therapy, indicating this interaction between improving pulmonary outcomes and improving kidney outcomes. So to conclude, AKI and ARDS are multifactorial. They involve systemic inflammation in multi-organ failure. There's significant organ crosstalk between these organ systems. But within that, it's undoubtedly true that fluid overload is bad for your kidneys and bad for your lungs. And what is generally true is that what's good for your lungs is good for the patient and the kidney. And it's important to note that as nephrologists, we are experts in the provision of renal replacement therapy, and renal replacement therapy is a vastly successful treatment that has been present for 70 or 80 years with increasing sophistication, and is a far more successful therapy than ECMO, which is highly technical and very difficult to administer, and therefore we should take some pleasure in the fact that we can adequately support the function of our organ to perhaps spare the function of the other organ. And, but overall, when it comes to fluid overload and improving the health of our patients, it's better prevented, as established fluid overload may be much more difficult to resolve, and this requires early attention to fluid balance. But that doesn't mean early attention to just fluid removal and unselected. It means early attention to the maintenance of the appropriate fluid balance in our patients. And with that, I will conclude. Thank you.